The period from the early 1990s through the first decade of the 2000s marked a decisive change in how modern societies understood and treated pain, and in how prescription opioids moved from tightly guarded tools of acute care to widely used agents in everyday medicine. This change did not happen by accident. It was propelled by clinical advocacy that emphasized undertreated pain, by accreditation standards that pressed health systems to measure and respond to pain consistently, by marketing that framed new formulations as both humane and manageable, and by economic forces that rewarded volume. The result was a rapid expansion of opioid prescribing for chronic non-cancer pain, followed by dependence, diversion, and mortality trends that revealed the downside of a policy and practice swing made without adequate safeguards. Advocates in palliative care and oncology had long argued that clinicians underestimated suffering and allowed patients to endure avoidable pain. That critique was compelling and, in many settings, accurate. As inpatient medicine matured, campaigns emphasized routine assessment. If blood pressure and heart rate were recorded at every visit, pain should be recorded as well. Accrediting bodies and professional organizations encouraged or required documentation. Numerical scales entered charts as default fields, and satisfaction metrics linked analgesia to perceived quality. The intention was to correct neglect. The unintended effect in many clinics was to equate rapid reduction of any reported pain score with high-quality care, even when the long-term consequences of the chosen method were poorly understood. At the same time, pharmaceutical companies introduced extended-release opioids and promoted them as innovations that would provide steady analgesia with lower peaks and troughs. This framing suggested better function and fewer misuse risks compared with immediate-release pills. Sponsored continuing education, branded materials, and speaker programs repeated several themes. That chronic pain was underdiagnosed, that opioids, when used as directed, carried modest addiction risk, that concerns about dependence often reflected old prejudices, and that new pharmacokinetic designs would reduce the temptation to escalate dosing. Many clinicians trained to relieve suffering and pressured by throughput and satisfaction scores accepted these premises and wrote prescriptions accordingly. A concept popularized during this era, pseudo-addiction, illustrates how clinical interpretation shifted. Behaviors that looked like drug-seeking were reframed as the understandable actions of patients whose pain was undertreated. The proposed remedy was to increase the dose. In some cases, undertreatment was real, and increased analgesia improved lives. In many other cases, this lens discouraged careful differential diagnosis of anxiety, mood disorder, trauma responses, or developing dependence. It also shortened the gap between a first prescription and the normalization of long-term, high-dose regimens. Prescribing numbers rose year over year. Primary care, dentistry, orthopedic practices, emergency departments, and post-operative clinics all played roles. Chronic low back pain, headaches, fibromyalgia, osteoarthritis, and a wide range of musculoskeletal complaints, conditions with complex biopsychosocial etiologies, became frequent indications for long-term opioid therapy even though high-quality evidence for sustained functional benefit was limited. Insurance coverage patterns, which often placed fewer hurdles on pills than on multimodal pain care, reinforced the trend. Physical therapy, cognitive behavioral approaches to pain, and interdisciplinary rehabilitation required time and coordination. Prescriptions could be written in minutes. Diversion and non-medical use escalated as supply expanded. Medicine cabinets became de facto distribution points for families, visitors, and teenage peers. Clinics with cash-only pain management models concentrated high-dose combinations and drew patients across state lines. Pharmacies that filled large volumes without consistent scrutiny turned into predictable stops for trafficking networks. Some prescribers operated in bad faith. Far more acted in good faith, but within a system that rewarded speed, and equated analgesia with satisfaction. The clinical reality inside exam rooms was conflicted. Many patients reported immediate improvements in sleep and activity after starting opioids. Over time, tolerance eroded these gains. Dose escalations delivered diminishing returns, while side effects, constipation, hormonal changes, hyperalgesia, sedation accumulated. When prescribers attempted to taper, withdrawal symptoms and the subjective experience of amplified pain made reductions difficult. Relationships between patients and clinicians suffered as expectations diverged from outcomes. The same medications that had initially symbolized compassion began to symbolize suspicion and anger. Regulatory and legal structures lagged behind practice. Prescription drug monitoring programs were patchy, often slow, and not universally checked. Labeling and risk evaluation tools evolved gradually. Early warning signs, overdose clusters, neonatal withdrawal syndromes, rising treatment admissions were visible but siloed. When enforcement did intervene, the response was frequently reactive. Raids on egregious clinics, license suspensions for outliers, and pharmacy audits. These actions were necessary in specific cases, but did not change the broader incentive matrix that still favored pills over comprehensive pain care. The economic map of the crisis reflected long-standing vulnerabilities. Rural regions with declining industries and limited access to specialty care experienced high prescribing and high mortality. Urban neighborhoods, facing structural unemployment and housing instability, saw rapid diffusion of both prescription opioids and, later, heroin. Communities accustomed to viewing drug policy through a criminal lens confronted the fact that dependence now spread through legal channels and among populations that historically had been framed as distant from drug markets. The social perception of addiction shifted uncomfortably. Compassion grew in some quarters, but did not erase decades of punitive reflexes in others. As prescribing expanded, a parallel market adapted. Extended release formulations could be manipulated to defeat slow release mechanisms, producing rapid, high doses. Tamper-resistant designs, introduced later, reduced some forms of manipulation, but did not remove demand. Many individuals who lost access to prescription supply through reformulation, price, or policy change shifted to illicit opioids. This sequence belongs more to the following decade, yet its seeds were sown in the period under discussion. Systems built to favor pills created large groups of people physiologically dependent on opioids, without durable alternative supports in place. Clinical guidelines responded slowly and then decisively. Early documents endorsed liberal prescribing for carefully selected patients under close monitoring, but specifics were sparse and assumptions optimistic. Later iterations put guardrails in place. Clear functional goals. Limited initiation in opioid-naive patients. Preference for lowest effective doses. Caution above specific daily morphine equivalent thresholds. Avoidance of concurrent sedatives. Routine checks of prescription monitoring data. Urine toxicology to inform, not punish, care. And time-limited trials with discontinuation plans when benefits did not outweigh harms. These recommendations reflected accumulating evidence that long-term, high-dose therapy produced modest average pain relief, uncertain functional improvement, and significant risks. Health systems began to retool. Some replaced blanket satisfaction metrics tied to immediate analgesia with balanced measures that included safety, function, and patient-reported outcomes beyond pain intensity. Interdisciplinary pain programs expanded where financing allowed. Physical therapy, occupational therapy, psychological therapies, sleep interventions, antidepressants, and anticonvulsants with evidence in neuropathic pain and interventional procedures were indicated. These approaches were not quick fixes and demanded greater coordination, but they aimed to deliver durable gains rather than short-term relief followed by escalation. The legal landscape shifted as evidence accumulated regarding misleading claims in marketing and the downplaying of addiction risk. Litigation against manufacturers and distributors argued that sales strategies overwhelmed caution, that suspicious orders were not adequately flagged, and that communities bore the downstream costs in healthcare, law enforcement, and lost productivity. Settlements and judgments in later years would finance elements of treatment, prevention, and harm reduction, though allocation and accountability varied by jurisdiction. The period from 1990 to 2010, in retrospect, appears as the setup for these legal reckonings. Within hospitals, perioperative and inpatient pain management underwent reassessment. Protocols that had once relied heavily on opioids began to incorporate multimodal regimens. Regional anesthesia, non-opioid analgesics, and non-pharmacologic techniques to reduce the need for high doses after surgery. Discharge practices tightened to reduce surplus pills. Pharmacy and therapeutics committees scrutinized order sets and default quantities. Education for trainees emphasized both compassion and caution, replacing simplistic equations of pain score reduction with more nuanced goals that included mobility, sleep quality, and patient-defined function. Primary care bore much of the burden for unwinding long-standing opioid regimens initiated under earlier norms. Tapering required careful pacing to prevent withdrawal and to detect co-occurring anxiety, depression, or trauma responses that had been masked by analgesia. Abrupt discontinuation increased risk of harm and was discouraged where clinical discretion was supported by policy. Successful transitions often depended on expanding access to behavioral health and to medications for opioid use disorder for patients whose dependence had crossed into disorder. The period also exposed discrepancies in access to care. Communities with integrated health systems could offer alternatives to opioids and support for deprescribing. Communities relying on fragmented networks or fee-for-service models encountered gaps. Long waits for physical therapy, limited coverage for counseling, and few specialists comfortable managing complex pain without narcotics. In those settings, even motivated clinicians encountered structural barriers to safer practice. Medical education adapted unevenly. Some schools and residencies expanded training in pain physiology, non-opioid pharmacology, and addiction medicine. Others maintained cursory exposure. Continuing education slowly incorporated lessons from epidemiology and from primary care's experience with high-dose regimens, but the statutory requirements for ongoing training varied widely across regions. Where licensing boards and health systems required meaningful updating, practice changed faster. Where requirements were minimal, old habits endured longer. Public health surveillance improved. Better coding, faster reporting, and targeted toxicology allowed officials to map hotspots and trends more precisely. Prescription monitoring programs became more interoperable and more integrated into clinical workflows. Data sharing between public health, healthcare systems, and law enforcement became easier where privacy protections were understood and respected. Overdose fatality reviews brought clinicians, coroners, and community organizations into the same room to analyze local patterns and propose corrections. Families and caregivers carried hidden costs throughout the era. Neonatal abstinence syndromes rose as pregnant patients on prescribed opioids or diverted products delivered infants who required prolonged monitoring and gentle, structured care. Kinship networks absorbed responsibilities when parental capacity was compromised. Employers dealt with absenteeism and safety risks. Faith communities and civic groups provided informal support where formal systems were thin. The cumulative burden reinforced the insight that pain and addiction are not separable categories managed by different departments. They are intertwined realities that demand integrated responses. International comparisons during the period offered perspective. Countries that maintained restrictive opioid policies sometimes left legitimate pain undertreated. Countries that expanded access without preparation saw patterns similar to those in the United States. Countries that emphasized interdisciplinary pain care and cautious initiation avoided some extremes. None of these examples provide a template that fits everywhere, but they demonstrate that policy choices significantly shape clinical behavior and population health. By the end of the first decade of the 2000s, the direction of travel had changed. Reformulations of specific products, the spread of monitoring programs, more conservative guidelines, and growing public alarm moderated some prescribing flows. Yet dependence and mortality had already risen. As prescription pills became harder to obtain or more expensive, illicit markets met demand with heroin, and later, with highly potent synthetic opioids. The crisis that followed cannot be attributed solely to the clinical and policy decisions of 1990 to 2010, but those decisions created the conditions under which the next stage unfolded. Several lessons from this period now inform more cautious practice. First, measurement drives behavior. When systems reward immediate pain score reductions, short-term fixes dominate. When systems reward functional improvement and safety, clinicians diversify strategies. Second, marketing can overwhelm methodology. Claims of low addiction risk based on weak evidence should never substitute for rigorous independent trials and ongoing pharmacovigilance. Third, access without support produces predictable harm. Where health plans approve opioids but delay or deny physical therapy, counseling, and interdisciplinary care, prescribing will drift upward despite clinician intentions. Fourth, tapering and discontinuation require as much skill and planning as initiation. Fifth, addiction treatment belongs in the same clinics and on the same schedules as other chronic conditions, not in isolated silos. There is also a cultural lesson. Pain is real and deserves treatment. Equally real are the risks of a single modality response to complex, long-lasting conditions. The professional emphasis has shifted from eradicating pain at all costs to improving function and quality of life in ways that patients define collaboratively with clinicians. That emphasis does not excuse neglect. It acknowledges limits and redirects effort toward gains that the evidence supports and that patients can sustain. The period between 1990 and 2010 will remain an object of study because it reveals how aligned incentives and narratives can move an entire sector quickly and how difficult it is to reverse course once expectations set in. It shows how easy it is to conflate compassion with a specific prescription and how essential it is to build systems that make safer options the default rather than the exception. It shows, finally, that pain care and addiction care must be designed together, financed together, and taught together if either is to succeed without harming the other. Subsequent years brought sharper awareness, stronger guidelines, and expanded access to treatment for opioid use disorder. They also brought the rise of fentanyl in illicit markets and a new wave of deaths that demand further adaptation. Those developments belong to later chapters. The record of 1990 to 2010 stands as both warning and instruction. Expand access to relief with care. Measure what matters. Treat dependence where it appears, and never let urgency eclipse evidence. In practical terms, durable improvement requires specific replicable procedures, intake visits that include validated pain and function assessments, treatment plans that set measurable goals beyond numerical pain ratings, regular reviews that weigh benefits and harms, co-prescribing of naloxone when risk is elevated, avoidance of dangerous combinations such as opioids and benzodiazepines without compelling justification, consultation for complex cases, ready availability of non-opioid therapies, and a clear path to medications for opioid use disorder when criteria are met. None of these steps remove clinical judgment. All of them anchor it. Health systems that have implemented these steps report fewer very high-dose regimens, fewer concurrent sedative prescriptions, improved documentation of functional outcomes, and better linkage to addiction treatment when needed. Communities that pair clinical reform with harm reduction infrastructure. Syringe services, drug checking, widely distributed naloxone. Observe reductions in infections and deaths, even when illicit supply remains volatile. These are neither quick nor glamorous wins. They are the results of ordinary, sustained coordination across disciplines. The opioid era of 1990 to 2010 cannot be summarized as simple villainy or simple error. It is a picture of sincere efforts to relieve pain, strategic campaigns that emphasized best-case scenarios, structural incentives that rewarded speed and volume, and a policy environment that trailed behind practice. The costs have been profound. The response must be proportionate, honest about harms, precise about mechanisms, and committed to building alternatives that make safer choices easier to deliver at scale. If the central error of the period was to treat a complex problem with a single powerful tool, the central correction is to build care that is inherently multimodal. That care reaches beyond prescriptions to include movement, sleep, mood, social connection, purpose, and employment. It respects that pain is not only nociception, but also meaning, memory, and context. It treats dependence not as a moral verdict, but as a clinical state that can be stabilized and improved. In short, it abandons silver bullets in favor of systems. This orientation sets the stage for later developments in policy and clinical practice. It also clarifies the stakes for communities deciding how to spend settlement funds and public dollars, on more beds without aftercare, or on integrated networks that include housing, employment supports, primary care, harm reduction, and addiction medicine. The latter is harder to build and easier to neglect. It is also the only approach with a record of bending the curve in the desired direction. The era taught these lessons at great cost. The task is to use them without delay or denial, so that pain relief remains possible and the next generation inherits systems that do not repeat the same errors under new names.